Bravery is visible in all aspects of my students' new life in Australia. It starts with day-to-day events, like crossing the road for the first time with cars, navigating buses and trains to get to school each day. Everything is different. The food, the language, the houses, the smells, the noises, and the wildlife. It really is a shock to the system for many of our young people. For some of our adolescents of refugee background, they are also experiencing their very first day of formal schooling. Though they are usually learning their third, fourth, or even sixth language, it really is a privilege to be part of their journey. They also bravely navigate two cultures and often find themselves having more language and knowledge of their new home than their parents. The power imbalance this creates can be very challenging for them to navigate, as well as for their parents. I really think it's important that we keep this in mind when working with adolescents of refugee and migrant background. It's always a good idea to ask newly arrived young people if they would like an interpreter, even if they can greet you in English. They are generally very quick to gain those basic interpersonal communication skills, but not so much that cognitive academic language that they need for those tricky medical appointments. Speaking of that, I've asked some of my students this week to tell me about their experiences with doctors in Australia. So here goes. Directly their words. I like my doctor because he speaks a bit slower. He also explains it to my cousin who's been here for 10 years. Important. This is one of my favourites. Doctors in Australia respect us. They stand up when we come in to see them and they ask for us to come with them. Doctors in my country always sit down and then they go to lunch and they never come back. Sometimes I nod and say yes, but really, I don't understand. Another, I do not like missing days of school to take my parents to the doctor, and I definitely do not want to interpret for my parents when they go to the doctor. I'd like to take a moment here to thank interpreters for the incredible work they do in this space as well. I couldn't do my job without them, as I'm sure you couldn't. And I would like to acknowledge the challenges they face when interpreting words and concepts that young people may have no prior knowledge of, or may not even exist in their first language. I learnt this lesson early on when asking a new family to give permission for their child to attend water safety lessons at our local swimming pool. It seemed to be taking a very long time for the interpreter to be asking this question. But then he explained, the family have come from a rural village and they've never experienced a swimming pool. So I talked to them about swimming in a lake. The family were not happy about swimming in a lake. So I had to describe a small blue water with walls and no animals. The parent then realised, yes, I've seen that small blue water. They can go swimming. I can only imagine how difficult it is for interpreters in a medical setting. Aren't they gorgeous? My students have also taught me what it means to be resilient. Their ability to recover from setbacks astounds me and inspires me to keep seeking solutions, even when I feel I have exhausted all my options. They have also taught me that resilience does not have to mean bouncing back quickly. Sometimes it takes time. I was reminded of this by a student who recently graduated from our school. They'd had some significant trauma prior to arriving in Australia and had taken a full 12 months to fully engage with education. Fortunately, this young person had a supportive family member who'd taken them to a GP for a mental health plan, and her GP and psychologist had communicated clearly with the student, her parent and the school, which enabled us to make the adjustments she needed for a very gradual re-entry to school. Before she graduated, she wrote a beautiful letter to the school thanking us for our care and support and for not giving up on her. If they can be resilient, then so must we. Unfortunately, some adolescents don't have the support network at home to help them bounce back, and they need the education, settlement and health services to be resilient for them. But then I ask this: stay engaged even when the young person is not ready to engage. Reach out to the wider community for support and ideas, and be mindful that the young person who continues to miss appointments is most likely the person you should be working hardest to connect with. Okay, a few more words from my students. I like my doctor because she makes jokes and makes me feel like a real human, not a foreigner. I want a female doctor, but I don't know how to ask, so I just say I'm okay. My doctor does more than help me when I get sick. They help me to be healthy. They told my mum about junk food. Now I can never eat it. I think this is probably my favourite. I think doctors are braver than soldiers. I also want to know how they can cut into a person's stomach and still eat meat. Most importantly, the young people I work with have taught me to listen. For adolescents who may never have felt their voice has been heard before, listening is empowering and builds a sense of connection. And we know that developing a sense of belonging and connectedness is essential to maintaining identity and well-being. So if a young person comes to my door, and hopefully yours, listen. For the first time, they may be just needing a check-in, testing the waters, seeing if we care. But the next time when they really need us, they know we will listen. The young people I work with every day have rich and sometimes challenging stories to tell, and taking the time to understand that story can be invaluable to knowing how to help them heal, learn and belong in this new environment. An example of this might be an adolescent who shuts himself in small spaces, makes loud and threatening noises, and who regularly disappears when confronted by others. We could consider these behaviours antisocial, but if we take the time to know this adolescent's story, we learn that previously these same behaviours kept him safe in a very dangerous refugee camp. And now he needs the time, space and support to adapt to his new environment. We all see the world through different lenses. We all have cultural bias. But if we are aware of this and we listen to each other, we can achieve great outcomes for these extraordinary young people. Thank you.
Thank you, Jacki, for sharing your insights and your stories from your students as well. We'll now move on to the next section of tonight's program, which will be on community perspectives conversations. So I welcome to the stage our panel members and also Dr. Miriam, who will be leading this discussion tonight. So Dr. Miriam Wellauer is an experienced GP with a warm and approachable manner who enjoys working in diverse settings. She works in general practice and is particularly interested in women and children and adolescents' health. She has set up a clinic 1 day a week at Milpera State High School for newly arrived young people of refugee and migrant backgrounds. Miriam also holds a clinical diploma in palliative medicine completed at St. Vincent's Private Hospital, Brisbane, where she continues to work on the after-hour roster. Miriam juggles her work and raising 3 young kids, trying to reduce her carbon footprint and tailoring her own clothes. Please welcome Dr. Miriam. I'd also like to welcome our other panel members, Emile Nuba. So Emile is a former Rwandan refugee and recent former chairperson of the Federation of Rwandan Communities in Australia. Emile is an experienced mediator and peace-building specialist with a proven track record for conflict resolution, community-led peacemaking, conflict prevention, and restorative justice practices. With a strong academic background in law, criminology, criminal justice, and family dispute resolution, Emile is deeply committed to advancing lasting peace, social cohesion, and shared understanding across divides. I'd also like to welcome Sunay Nin. Sunay is a member of QPAS Youth Voice. Originally, she is from the Karen ethnic group of Myanmar and Thailand. She immigrated to Australia as a refugee in 2011. Now in her first year of studying a Bachelor's of Business and Psychology, Sunay offers a meaningful perspective on refugee healthcare informed by her own journey and lived experiences growing up in Australia as a refugee. I'd also like to welcome Huda Al-Khali, is currently a QPAS Youth Voice Group member, Vice President of Multicultural Australia Flag Group, and is currently working in the youth team at Multicultural Australia. Huda has a background in performing arts and is passionate about bringing her arts and advocacy together in advocating for refugee and migrant youth issues. Please join me in welcoming everyone. I'll now pass on to Dr. Miriam to lead this discussion.
Thank you very much, Decca. And I think it's a real privilege to be able to talk to people about some lived experience and the issues that adolescents might be facing from a refugee background. So I'd like to start, first of all, with that question: what kind of issues have you yourself experienced or seen experienced by members of your community as adolescents accessing healthcare in Australia?
Well, thank you so much. And I think what I'll be sharing this afternoon will come from what I have observed, what I've heard people share, and some of the experiences I have had as a young person. I think I'm sort of on the borderline. Some of the experiences I've had and some of the experiences that some of my colleagues have also experienced. I've already forgot the question. The question was what are
the issues that you think adolescents are particularly experiencing when trying to access healthcare in Australia?
Coming back to the mental health and how that looks in different cultures, different religions, different communities. There's, I guess, there's a lot of perspectives, and but to come back to the real issue that I've seen that some of our young people experiences on language, stigma, and a few other issues that I'll mention in a second. Something that really stands out a lot is on language. I come from Rwanda, and we don't seem to have a direct language and a direct translation of the, I guess, things around stress, trauma, mental health. We do not have the right language that can create a shared understanding of the practitioner and the young person or a patient who is there to receive care. The other one which I will strongly be emphasizing on a lot is around some of the taboos and stereotypes that comes with mental health. The direct language for mental health in our language is speaks to the person who has gone crazy, a person who has gone mad. And that in itself does not invite a space for conversation. and where quite often a young person has presented with a mental health crisis, um, there is a lot of shame, there's a lot of denial, and no one would want to be labeled as a person who has a sick mind, or a person who is going crazy, and a person who is going wild. Um, Privacy and around sensitive conversation on sexual health, as well as other health issues that can relate to mental health. There are things that we do not have the language and the terminology to be able, one, to understand what the practitioner is saying, and for us to put that in a language that the practitioner can understand. Therefore, two people can sit in a room, have a conversation, but those conversations are completely different. One has this particular lens, whereas on the other side, someone has a different particular lens, and that would, in the long run, lead to a lot of difficulties.
One issue that I've noticed within my community, I used to live in like rural Upper Queensland, so a lot of like the Karen people that moved there and like new refugees that settles into like regional areas, they often experiences like greater challenges because healthcare professionals may have limited exposure towards treating refugees. I think this is due to like disparity in access and quality care because in the city we often have more refugee specific programs along with interpreters and just cultural awareness teachings that a lot of healthcare professionals in rural regional areas don't really have. Because of the limited exposure, I've seen, I guess, the treatment towards people with refugee backgrounds often lead to more misunderstandings and just cultural miscommunication and just gaps in quality of the way they can like receive medical care. And I also would like to mention, as we mentioned, like translating. Growing up, I came to Australia when I was pretty young, so in 2011. This was like I come from a Korean background, so this was during the mass of just immigration. So we didn't really have a lot of like fluent Korean translators. With that being said, I used to live with my grandma, so I was kind of used as the sole translator for everything, and it was really difficult, especially when we had like medical appointments, and I was there just to like help translate things. But when it comes to like medical treatments or just things that was so complex that I couldn't really understand in English, let alone translate it in my native language. So this was a while back, so I hope it has improved with like the translating. But yeah, those are some issues that I've seen in my community.
Thank you so much. And just adding to what Emil and Sone have already said, one of the things particularly that I've seen within my own community, but also through my own experience with my family and my siblings, navigating the health journey has been the overwhelming amount of services that we get at one time, and also the complete opposite, where there's no services that can support you. Oftentimes, what can happen is when there's a range of issues that an individual or a family could be experiencing, there's obviously referrals that are put through, and during that process, sometimes there's an overlap. There's two services that are doing the exact same thing at the exact same time, which isn't really that effective when we're looking at the long-term, health journey. For example, my mum, she had a lot of hospital appointments and had to see a lot of specialists through her health journey, and I was a carer for her during that period, alongside my younger brother as well. Both of them had very different health needs during their journeys, and one time my mum told me that she received a call from the hospital or some sort of doctor, and they were asking her if she had an appointment that was coming up and she needed to come and visit the, specialist, and she declined. So I said, oh my gosh, no, we can't do this. You've waited 8 months to get that appointment. So I scrambled to call back that number that had called my mum. And where I saw from that experience was the importance of having those check-ins with whoever has referred you to a particular service, because sometimes the wait lists can be quite long. And during that period, we get busy, we have many responsibilities, and we obviously don't want to miss out on that critical care and to, see the experts that we need to see in order to receive that support. So, just being mindful about, who we're referring to and what services are actually appropriate.
Thank you. I've certainly come across that very problem in my own practice, with hospitals calling up patients and saying, do you still need this service? And I must admit, even when it's been really well explained, I think the power differential with a hospital calling and our patients wanting to do the right thing and please people, and they've said, oh no, we don't need it anymore, and I get the letter from the hospital saying that they've declined the service, and I get them back in and I say, no, we talked about this, you definitely wanted it. And it's a tricky one that we probably need to address with the hospitals, I think. So do you guys have any suggestions of things that healthcare professionals and providers could do better or differently with our refugee adolescent population?
I love soccer, and I usually, after work, go to the park and kick the ball around. But last week, I met with a family, and they had a young person who had experienced a lot of difficulties. He's a soccer player, and he wasn't engaging with the practitioner, and he was any efforts from the school to connect with the psychologist were completely denied. And I was called along to have a bit of a yarn and a conversation with him, and he agreed, and him and I attended the first appointment, and to that I had a yarn with the practitioner, and she asked, is there anything else? How can I best approach and work with this young person? Being a soccer fan, I prompted him to consider sports can be a conversation starter, and sport can help build those bridges of trust, and trust is key to building those relationships and cross a client to the other side. Very briefly, what she did, which I feel will be relevant to the question, was that she decided to spend the first 2 sessions just talking about soccer, and whenever they would meet in a consultation, they talked about sports, they talked about if you are engaging with quite a young male, to be more specific, in Africa, soccer is a shared sport. And after those 2 sessions, she was able to therefore build the rapport and the trust to talk about the actual real issues that this young person was going through. So understanding of time and concept and the expectations are quite different to what we feel if I was to put myself in that situation. There's time pressures, there will be KPIs that you'd have to meet in your role, but if you can have a room for flexibility and accommodate, build trust and rapport with the person on the other side of the chair, that will potentially contribute to a better care and better engagement. I always suggest to start with a sense of curiosity and our mental health from our Rwandan perspective. It's quite often tied to family, community, and faith. And having that sense of curiosity to understand different dimensions that are at play can also help build rapport and get a better engagement. Language is very critical. There's another story which I'll not go into very deeply, where there was a referral from a school as well, and a young person was referred to go to see a psychologist, and the mother thought that her son was breaking apart. His life had come to an end, and the way we use mental illness, mental health, as opposed to stress, sleep, energy, focus, can often provide a room for a much more rather rich and meaningful conversation. Most refugees have, if not all, speaking from my own personal experience, there is a lot of resilience that we work with, and as much as we migrate with conflict and mental health and a few other issues, we also do migrate with so much resilience that young men and young women as well, or young people who identify across diverse genders, can bounce back, and they, as much as they are trying to cross over the land for themselves, there's a lot of family and other cultural responsibilities that may tie into it. But bottom line, there's so much resilience, and if you can tap into that, and if you can tap into, you know, you've ended up here. Can we have a bit of a conversation around what is it that has led you to be where you are today? If I can reflect on my personal experience, I moved here when I was turning 15. Hadn't been to any decent schools. I was born in Tanzania, raised up in Zimbabwe. And for those who understand, who have learned a little bit about Zimbabwe, it had a bit of a timeline where the health and the education and all the systems collapsed. And in Hobart, being there in Australia for the first time, going to school for the first time, wearing a uniform, there was a lot of pressure, and it took my mentors and people who helped me dig deeper into my resilience. You're here, you've come a long way. Let's look at what are the practical tools that have sustained you, and how can we tap into them to take you far? I'll probably stop from there.
Something that I've noticed is that when refugees first access healthcare when they just arrived, is that there's a very distinctive gap with the medical history, and GPs, when you first arrive to your appointment, you have that initial appointment where they just get to know you more, and there's a lot of barriers that refugees will face. Just they might just feel too fragile, or just they can't really articulate the words properly. And then GPs are kind of left just scrambling to connect all the pieces together. I wish that healthcare providers could approach this a little bit differently. I feel instead of just relying on patient recall, they could have more of a structured intake process. So these can include collaborating with refugee health services, and just collaborating just to get to know critical information that they have experienced in the past. This could really help break down the gaps and knowledge gaps that they can face.
One thing I would say that I would really love healthcare providers to keep in mind is please, 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 please acknowledge young carers who are part of their families' journeys, especially refugee and migrant youth. I think sometimes, as a young carer myself, for both my mum but also my younger brother, we play such an important part in their health journey that sometimes we're actually forgotten. So a little bit of a background, my younger brother, he had developmental challenges. So he was diagnosed with ADHD and developmental learning disorder. He's the only person in our family who has had these developmental challenges, and it was the first time as a family but also as a sister to my younger brother that we had to navigate that journey, having no idea what these conditions were to begin with. And through that journey, I realized that at the beginning, I would often come with my mom and my younger brother to his appointments and to these assessments. And oftentimes I felt there were certain things that were not covered or shared that I had noticed myself personally within his behavior and the signs that I was picking up on. And I was never asked. Hey, Huda, what did you notice? You know, you always seem to be coming to these appointments. And as someone who was quite young during that time, I mean, I'm only 21 now, I'm still young, but I was very young when that journey was first started. I felt very shy. I was scared. I didn't know how to approach that conversation. There is a power imbalance. Let's be very clear about that. I'm only my brother's sister, and that's it really. And you've got all of these doctors and specialists that you have to start these conversations with. And how do you make it clear? Actually, I've observed this. This is what I've noticed, and this is what I think is important. So please make sure that you acknowledge the young carers that are in through that process, because we do have a lot of things to say and we're willing to listen and learn. But in order for that exchange to happen, we also have to have a voice, especially, during, caring for other people. So that's what I would really love to say.
Thank you all again. Sune, I think you really touched on something there that, a problem with the health system in Australia in general is that there are lots of separate entities that don't necessarily talk to each other very well, and a lot of people are telling their story over and over again. And I can only imagine the extra challenges that are brought in when you've got the refugee background and working across language and culture. We might end off with a question about how clinicians can navigate the increasing independence that we get with adolescents, and the need for adolescents to many times have confidentiality, talking to doctors or other healthcare professionals potentially without parents or other family members there. And if you'd like to talk a bit about confidentiality, how we walk the line between that very important issue of confidentiality, but also the importance of recognising family and community in cultures where that's really important.
I think most importantly is just providing like one-on-one consultation, especially with like adolescents. It can be really intimidating to go to the appointment by yourself, but it is also like an experience, especially if they don't feel comfortable having their family members around. Another note is like framing sensitive matters such as sexual health as overall physical well-being, especially if it is like a family setting. This could just frame the topic to be a bit more friendly and a bit more approachable.
Because adding to that, our families are living in, navigating to a different world. One where there is all the rules around privacy, confidentiality, private space, as opposed to another world where all decisions are delivered through a collective way, and that often includes health. And it's a bit of a tricky situation, but and I think acknowledging both systems usually helps a lot. That we come from a system that can be quite individualistic. We understand that you make decisions as a family, you make decisions as a community, and how do we make it work in situations where we might need to withhold information from the other party. And I think for me it comes down to being respectful and being aware of the vulnerabilities and the risks involved from yourself as a practitioner and to the family. Where I have seen go completely wrong has been situations where practitioners will come and, this is the document, we will share this or not share this, and the family have actually left the room because for them, they felt that as a mother, they felt that decisions for their adolescent, they had to be involved and they had to be consulted and they had to be part of that finished product. So I think being respectful, being aware that the way we formulate and come to decisions may not necessarily reflect the way that your clients, your patients will make a decision and come to that final step. And it is being respectful at all times.
I would say that when it comes, I'm going to take the sexual health lens in answering this question. I think coming from the family perspective, like parents or carers who are much older and they've got children and adolescents, I would say that address the misconceptions that when we hear, I know that for my parents, when they hear sexual health for young people, the first thing that goes through their mind, are you trying to encourage my daughter or son to engage in these activities? Like, that's the first thing that goes through their mind. And it can be very hard for them to take that all in and actually make space for the questions that they might have, and also acknowledge those misconceptions and being like, no, actually, we're not encouraging it, but we're just trying to share the important information that is critical for their health and well-being. That's the focus. It's part of, our human experience. It's a part of our health journeys, and we need to share that for their safety and for their well-being. So really making that clear when addressing misconceptions. And I think even with my own experience, when those misconceptions are addressed, between my parents, with the doctor, and separate appointment for myself, is very, very useful, as Sone has mentioned, about having those separate consultations and appointments and having a different approach for who you're talking to. So I think that makes a really big difference.
Oh, thank you very much, everyone. I just wanted to very quickly make the point that I'm very privileged to be working in a high school where I see adolescents almost exclusively on their own without parents involved, which makes a lot of this quite a lot easier. I don't know if much will be said about it, but I thought I'd quickly explain. The GPs in Schools program has been around for a bit over 4 years, and there are GPs in 50 schools throughout Queensland. So you may find that the school in your local area where you're working has a GP. It might be interesting to find out if that is someone who you could maybe make contact with and work with as well.
I'll keep that slide up for a bit longer for the GP in state schools. But this presentation will be shared with you in the end as well as it being recorded. Thank you to our panel for their insights and also raising some very interesting points and interesting issues as well in adolescent health and navigating this system. So I welcome you to take a seat now, and we'll invite our next guest. Thank you again to our panel members. This way. Oh, there we go. I'd now like to invite our next speaker onto the stage. Please welcome... Please welcome Dr. Henry Goldstein to the stage. Dr. Henry is an adolescent and young adult physician and general pediatrician based in Queensland. In 2013, he co-founded Don't Forget the Bubbles, a pediatric medical education website based on the principle of FOAM, free open access medical education. He has a passion for innovation, understanding health systems, youth-appropriate healthcare, and knowledge translation. His career mission is to support doctors and the health system to give better, more human care to children and young people. Please join me in welcoming Dr. Henry.
Thanks very much, Jacki. Good evening, everybody. I'm going to pace because that's what I do. Before I start, I will acknowledge the traditional custodians of the land on which we meet and acknowledge their enduring connection to the lands and the winds and the waters. I pay respects to Aboriginal and Torres Strait Island elders past, present and emerging, and respect to First Nations people present today, and that sovereignty was never ceded. So yes, I'm an adolescent and young adult physician, and we're reasonably rare beasts in the wild here in Queensland. There's 5 of us, which means there's more paediatric cardiothoracic surgeons than there are adolescent physicians. When I'm talking to young people, I have the privilege of saying, hey, I used to be a paediatrician, but like my patients grew up. And what that means is, much like on our previous panel, I have the privilege of talking about things like sex and substances. I also have the opportunity to work in a whole range of different clinical settings. I did most of my training at the Queensland Children's Hospital, and that was probably one of my first encounters with Refugee Health. I was working there in 2018 when the kids off Nauru mass transfers began to occur, and provided inpatient care for that cohort. But these days I work in the Youth Detention Centre out at Waco and Youth Remand and Westmoreton. And I also work at Clarence Street, Marta, which is an AOD service for 12 to 25-year-olds. The work at the Children's Hospital is ongoing because we're trying to work on an adolescent medicine service. So, I love that the panel mentioned most of the things that I want to talk about as well. Because it means that my presentation is going to come very much from a theory-based perspective. And when I started in adolescent medicine, there's no standard textbook, there is no Murtaghs, there's no Harrisons. It simply did not exist. And so we actually co-designed the Magenta book with about 8 young people here in Queensland, which is about providing safe and quality care to adolescents and young adults. So if you haven't already taken a snapshot of this QR code, this would be the moment. It will come up one more time if your phone's too far out of reach. Just a few more. Magic, so we've done that one. So I mentioned before some theoretical frameworks, and this is how I think about adolescent care. We know that adolescence starts somewhere between 10, which is what the WHO says, and 12, which is what most Australian government departments say. And really, that's the onset of puberty. I am not a paediatric endocrinologist, and I have no desire to be one. But adolescence and young adulthood goes all the way down to, or up until 26. And if you've done your health professional training in the last quarter of a century, you probably saw that fMRI slide of developing brains. Someone would have said, the young adult brain is not fully developed. And you might have thought, well, stuff you, I'm old enough to be here. And I think that gets at the heart of one of these striking challenges we have in the care of adolescents and young adults, that the health system is based on deficits. Stuff you can't do, stuff that's wrong with you, stuff that's broken. And that runs counter to that core pillar, evidence-based pillar of what is youth safe and quality care for young people. And that's strengths-based care. So I'm going to talk about strengths-based care in a moment. But through all this time, there are a number of central questions that young people have. As an early adolescent, your central question tends to be, am I normal? Am I normal? And so, yeah, puberty is tough to go through. So is a change of countries. So is a change of anything, really. And here in healthcare, we have got the striking social privilege of being the arbiters of normal. And unlike your exams, where if you say the word normal, you lose marks, in the care of our early adolescents, please, whenever you can, give them the normal. Do not invalidate them. Don't give them the invalidating normal, yeah, that's fine. Take their time. You know, our best care is built on listening and looking. So when you do a physical exam for an early adolescent, validate you are normal when appropriate, and when not, then I trust you do good clinical care. As a middle adolescent, your central question is, where do I belong? And that is a hard question for the cohort that we're talking about. In the panel, our wonderful speakers, and Huda in particular, talked about our complex system needing navigation. And I know from working in emergency departments and from referring to emergency departments that bearing witness to that fight of are they under gastro or surgeons, is this referral going to adults or pediatrics, is, as a professional, it's infuriating. And as a young person who is having a developmentally formative experience of healthcare, that's a systems level rejection. It's saying, you don't belong here. And that's a real challenge. But the opportunity here, as generalists, is that we care for people across that, weird, imaginary age gap. And so that message of all people are worthy of care, independent of your age, needs to be heard in this cohort. Because most of us have had that experience of trying to provide healthcare for a young person or for their family who don't trust us. And that's hard. And so if during your developmentally formative experiences of healthcare, you receive repeated systemic rejection because you're too old or too young or too sick or too well or not mentally unwell enough or too mentally well or whatever, then we're doing harm. And we have permission and the societal power to advocate for young people around that. So at the end of the Magenta book, it talks about youth-friendly health services. And so when you're thinking about your own practice and the work that you do, there's some ways that you can think about that. But in your day-to-day, acknowledging everybody is worthy of care, thanks for coming, is a really, really powerful thing. It also means that those letters of advocacy, all those phone calls, are so incredibly powerful. I'm talking about power a lot, right? Because we have that, and we're talking about a group who, for whatever reason, system issues, interface issues, experience poor care as a consequence. As a young, sorry, I'm going to talk a bit more about belonging, hey? Because helping a young person navigate through that is one of the core aspects of why we're here this evening. Where do you belong? And it's possible to belong in your family, and it's possible to belong in your school but not in your sports team. It's possible to belong in your culture but not in your country. And appreciating the difference between those requires some incredibly nuanced language, and language that I would warrant is particularly challenging through interpreters. But those are very different things, hey? How do you feel like you belong? The amazing opportunity here is that when we think about the tasks of adolescence, one of the core tasks of adolescence is identity exploration without overcommitment. Without overcommitment. I'm not standing here in what I wore when I was 15. I would imagine that most of you are not. Miriam designs her own clothes, so that might be a different thing. And fashion goes around again, and that's okay. Identity exploration without overcommitment. And there's only 4 ways that we can really do that. 4. One is to become a parent on a birth certificate. One is a tattoo gun. One is a criminal record. And the last is the medical record. And so thinking very carefully about that thing that we wield every day. And look, I work mostly in the public system, and I know how far that stretches. If one particular 3 or 4 letter acronym enters your health service here, you can be thousands of kilometres away and receive prejudicial care because someone wrote BPD. Yeah? And so thinking that's one of the reasons we're so mindful around that. But the good news is that pretty much everything else is up for grabs, including where a young person belongs. And we know we've heard already from every speaker so far this evening about the resilience of young people, and I think it's worth reflecting around that. As a young adult, your central question is, what are my values? And those values include, are you willing to work just enough nights and weekends to justify going to med school that you want to tolerate that for the rest of your career? This is how people are treated when they ask for help. And I think Hu's points around walking back some of those misconceptions around health, there's a real opportunity in that space as well. So I talked before about strengths. And I've mentioned societal power. I guess the other thing that goes with that is that we're society's secret keepers. But when we highlight, so in the average day, the average 14-year-old who is at school in Australia probably sees like 5 school teachers, right? And if you're used to the kind of situation where the teacher holds a lot of power, which certainly when I was growing up they did, when they praise you, it really feels amazing. Yeah? And when you get told off, it sucks. Okay. How often would you see the school principal at school? Maybe once a week? Maybe at an assembly or something? Yeah, and if you happen to be standing on the stage receiving an award, that feels amazing. Yeah, you put that award on the mantelpiece at home, or you put it in a place that you can see it and it reminds you of how fantastic that feeling was. And the other side of that coin is, if you're in the principal's office, that really, really lands. So I guess the question I have for everybody here is, in the average week, is a young person more likely to see their school principal or to see you? Because as health professionals, that's the kind of societal power we hold. And I'm talking here about those small rejections that we experience when a young person feels safe enough to share with us that they had a crack at cannabis for the first time. Yeah, or that they got really drunk and stayed out 5 hours late. And they feel safe enough to share that with you, so you're doing pretty amazing work. But in those responses, that's where that trust sits, because that rejection from us, that telling off, explicit or implicit, that really, really lands. Right? And I think we forget that sometimes because we train in big, big groups. We work in, often multi-practitioner practices. So the next piece is around relationships. Now, the person who trained me in adolescent medicine is Professor Denny, who works at Mahadeo. And he did the Youth New Zealand survey, which started about 23 or 4 years ago. And over that time has surveyed 30,000 New Zealand adolescents and done a thing that these days is pretty commonplace, but 25 years ago, branching algorithm questions were very hard. So they took computers to the schools and then plugged them all in and tried the Nokia devices when they were a thing. But through that data, he's established kind of what we all know to be true, that your health outcomes and your mental health outcomes are better if you have an adult who loves you and you love. So when I'm teaching to our pediatric colleagues, I spend a lot of time in this space saying, yeah, we know we do that, we're pretty good at that, but see the young person alone. And when I'm talking to my adult colleagues in their care of 19-year-olds, I'm giving them permission to pick up the phone and talk to the parents, not in great detail, but to find out who is the person who loves you and you love. And it's going to change depending on where a young person's up to, what their cultural requirements are, and how they make decisions. And it's our responsibility to have a degree of flexibility in when we're talking about that 16, 18 space, because we're talking about some really significant decisions. And making that with a person who loves you and you love tends to lead to better outcomes. So leverage those relationships. The next core pillar of adolescent care is around skills. Actually, sorry, let's talk a bit more about relationships. I really loved the example that was given around spending time with a young person. And it's hard because whilst they're in your office, you can build them to a point, but also what are they there for? And if the relationship is the intervention, right, then you are doing good work. My colleagues at the Mahadeo Drug and Alcohol Service, Clarence Street, they've shared a few papers around that, essentially saying that the relationship is the intervention. And how do you build that relationship? How do you build that relationship across cultures and language barriers and many other challenges? And I've got to say, often it's around noticing. Noticing that you as a person in the room and the other person that you're providing healthcare, this emerging adult, this adolescent, who trusts you enough to sit alone with you in a room and is learning that skill of, playing the game of healthcare. Safely noticing things. Notice the colour of their shoes or the fact that they've got a feature nail. And I can tell you, most young people are reasonably surprised when a middle-aged white man points out they've got a feature nail. But noticing and working on that relationship. And if it's about football, then fine. Everything I've ever learned about Call of Duty or Fortnite, I learned from a young person. I've never played either game. But what I can tell you is that Call of Duty, despite it involving headshots and automatic weapons, is fundamentally a more social pastime than anybody playing Candy Crush. Okay? So for the young person who gets on Discord and tees up a game with 4 or 5 of their mates and it's, real-time contemporary communication with headphones, there's a lot of connection in that. Age-appropriate connection, developmentally appropriate connection, socially appropriate connection. And it's a very, very different experience to the, profound isolation that comes with something like Candy Crush. And I only know that because I just leaned into that question. What game do you play? The data says that 85% of Australian adults play computer games. So we probably need to know more detail than do you just do gaming. Okay, skills. I mentioned Call of Duty. I can't do headshots. Probably couldn't boot it up. But young people can, and they're gaining those skills all the way through adolescence and young adulthood. Finding out where a young person is up to in a particular set of skills is really relevant to their care. Okay, it gives you the opportunity to highlight what their strengths are. But it also means that we can dispense some life skills that are appropriate for our environment. And the number of times that I talk to young people about how do you write up your homework diary? That's a brief intervention, right? But it's something that enabled me to, survive at least through medical school, which is probably the bar for entry into this conversation. You have significant life skills. Please share them with young people in bite-sized chunks whereby it improves their life. And amongst, underpinning all that is context. So I tend to start seeing young people alone once they're in high school. So anybody who rolls in that high school uniform, even if it's just for a few minutes. And I'd say normalizing that is really, really key. This is about young people moving towards interdependence. This isn't independence. There's no such thing as that lone wolf. We all exist in communities. And a young person's moving from their child support network to their young adult support network. All right, this is that whole graded autonomy piece. So when appropriate, noting that we use a reasonably individualised model of care here in Australia, or individualistic, is I'll say, I'm an adolescent physician, so I kind of get it easy, right? People are expecting this part of the conversation. But I say, I see young people for a period of time by themselves. We're going to start all together. And then I will spend some time with the young person, and then we'll get back together, or all get back together at the end to make sure we're on the same page. Because I think it's really important, if a parent can model their child's medical history, then the young person is learning that skill from their parent. And when I get to an appropriate starting point for the young person, I'll say, okay, I feel like we've got enough to make a start here. I'm going to get you to step out. It will probably be about 10, 15 minutes, 25 minutes, 40 minutes, depending on the consult. I'm really lucky, I've got lots of time. And then at the end, I will often work through some of the language that I've used with the young person about what I'm going to say. It's also a good way for me to practice it, to summarise and to share with the young person, and to make sure that I'm not using absurd clinical language, because we're all prone to that occasionally. So I use a HEADS assessment as a structured way of thinking about a psychosocial assessment for young people. Hands up if you've heard of a HEADS assessment. Cool. So it's a semi-structured interview, much like Spikes for Breaking Bad News. It's validated for clinician comfort. So it's not the only way to do that work, but it's a helpful one. H is for home or homeland. Where do you feel like you belong? Do you have your own bedroom? Is it a safe space? If a young person says that they spend 3 nights a week sleeping at their friend's place, then the conversation about sex later is going to get easier, hey? Education and employment, and often that's a surrogate conversation around money and financial stress. A is the activities. Like, what is the thing that you do that gives you joy? We saw that beautiful photo of the young men playing basketball at the start, and those smiles, hey. Finding out what those activities are and thinking, I'm often thinking, are they planned? Are they pleasant? And are they structured? Because structured means that everyone leaves at the same time and no one's left behind feeling abandoned, right? And rather than those kind of spontaneous, unexpected social experiences, activities. And everything I learn, I've just asked the next curious question. Oh, what is that? How do you do that? D is drugs or substances. Where are you up to with substances? What do your friends use? What have you used? 80% of young people in Queensland have had a crack at cannabis, so it's a pretty safe place to start. And then, as we know, Australia is bathed in alcohol culture. The S's are for sex, which most paediatricians are really adept at avoiding. Suicide and safety. And the reason that I go through this framework every time with a young person is not just to understand context. It's also to do, a risk screen, which is part of our work. But amongst all that, we are modelling that these socially taboo topics are safe to discuss in healthcare, right? Because we are society's secret keepers. And lastly, how do I get out of that conversation? If I'm getting strong social no that a person doesn't want to talk to me about sex, that's fine. I will say, there's a few different sexual health services in Brisbane. We have on the south side one called PASH, and the one in near Roma Street is called Biella. They're free. They don't card you at the door. You don't need a Medicare card, and their medical record doesn't talk to the main public hospital medical record unless we specifically ask, so your other physicians don't need to know. And so those brief interventions are for me an exit strategy for any of those conversations, which allow me to both model that, hey, you could ask me about sex, but if you don't want to, that's fine. And it sits in that middle space, time and time again. I've mentioned our role as society's secret keepers a couple of times. And so that piece around confidentiality. The last thing I want to talk to is that there's an evidence base around talking to young people about confidential healthcare. So every young person I see, even if it's for the 17th time, I will talk to them about confidentiality. I will say, healthcare is confidential. That means that it's secret and it's written down here. I will write notes at the end of the consult. And I can't share those notes with anybody outside of your care team except in 3 situations. One is if you're going to kill someone. One is if someone is hurting you or you're hurting yourself. And the third is if you're thinking about killing yourself. And if you want to share those with me, I'll still give you exceptional healthcare, I promise. I say that every time. And it often means that at the point that we're inviting a parent in and a young person has shared something around that, we've got the opportunity to troubleshoot. You know, can I tolerate the fact that this young person is self-harming much like 8% of their age-matched peers? Or is it something that I will have a full and frank conversation with the parents? Or how do we make it so that this young person can save face and maintain their dignity and self-respect, but also get the care they need? I will literally talk about adolescent care all night if you let me. But I'm going to leave it there, and just here's another flash at the QR code, which may or may not work because. But that piece of, you know, young people are coming to us for healthcare, not health judgment, hey? And we get the privilege of delivering that every day. Thanks.
Thank you. Thank you, Dr. Henry, for sharing your perspective. I gained a lot of insight from it, in particular those 4 pillars that you spoke about, and the importance of, I liked what you said earlier about that building a relationship is that intervention as well. So thank you again. I'd like to now welcome to the stage our final guest speaker for tonight. One second. Yes, I'd like to welcome our final guest speaker for tonight, Bethany Mahadeo. I do hope I pronounced that correctly. Please welcome to the stage Bethany. Bethany is an occupational and art psychotherapist at Milpera and HEAL coordinator. Bethany originally trained as an occupational therapist, with her professional life evolving mostly in the world of inpatient adolescent mental health care in Australia and the UK. Along the way, she discovered the enormous value the art added to therapeutic engagement with young people, and in 2005 to 2008 undertook further training at the UQ School of Medicine in art psychotherapy. Since 2006, she has been privileged to work as an art therapist and occupational therapist with newly arrived refugee adolescents, and she coordinates the HEAL program, a school-based mental health service at Milpera State High School. Please make her feel welcome.
Thank you, Decca, and thanks everyone for having us here tonight. It really is a privilege to get to talk about some of the luckiest work I think that exists in the world with some of the most amazing young people that you would ever have the joy of meeting. I've got way too many slides, so I'm going to take you on a bit of a whirlwind through a little bit about what HEAL does, a little bit about why being creative with young people is really effective, a little bit about my view as an OT and the way that I frame things sometimes with young people. I can't really add a lot to the cross-cultural conversation tonight. There are people much more expert than I am talking about that tonight, but maybe a few points about what we see at Milpera, and then perhaps some questions about where you might go next from here. So HEAL started in 2004. I'm going to give you the very short version. It is a specialised mental health and wellbeing service for young people of refugee and refugee-like background. We use creative arts therapy, and really the whole purpose of HEAL at Milpera is to help young people become available for learning. It started small, but we have now got this amazing space. We have some really creative and incredible resources that have taken a very long time to curate. And we have this lovely, sometimes messy, really engaging, welcoming space for connection and safety. We've got staff there 5 days a week, all in a part-time capacity, and everyone comes from a different professional background, which is great. We've got people who have been teachers, social workers. I'm an OT. We've got film and television industry experience. We see young people, usually on a weekly basis for individual sessions, also in a group setting. And we're also there really embedded in the school to respond to things that are happening for young people and for their teachers during the day at school. We have this incredible array of ethnicities and countries represented at Milpera, and an equally complex and varied number of stories around the way people have arrived in Australia, their migration or refugee journey, the kind of visa they're on and what that means for their settlement. Settlement is absolutely, an incredibly varied experience for people. It is chaotic sometimes, it is rich, it is scary, and we really should, as health professionals, never underestimate the impact of that settlement process on how a young person is presenting. We've got all the usual issues facing adolescents, which are myriad. They've got all the social media stuff that all of our kids are dealing with, but they're also dealing with the fact that there are current conflicts going on in the place that they have come from. They're being exposed overnight, often to really graphic images, sometimes not true images either, which is equally difficult and scary. And so they're navigating this constant wave of information and really stressful material that's going to be affecting their parents as well, and the whole environment that they're getting up into in the morning and having to exit to get out into the world and into the day. Often a journey that involves racism, often a journey that involves getting lost, not knowing where to go, being late. They have big days before they get to see you. And we know, of course, that the impact of trauma that they have experienced, I'm not going to try and explain it to you tonight. I know you already know about this, but trauma impacts learning. It disrupts memory. It especially, most importantly, disrupts relationships and trust. But it means that a young person is not always really there in the room, ready, receptive, able to hear what you've got to say to them. So we are very fortunate. We get to bypass some of that talking. We know that trauma is held in the body. We get to work with young people creatively, help them to express themselves, whether that's through art or music, often yoga, storytelling, other body-based techniques, breathing, grounding, helping somebody get regulated in their nervous system, which is no small task. Using creativity is amazing with young people, and even if you're not an art therapist or a music therapist, there's no reason not to incorporate it into your daily interactions with young people. It allows you to access subconscious material incredibly quickly. For one thing, it's less threatening. It doesn't require being proficient in English, which is amazing. And being in that state of flow, if any of you do anything creative in your own lives, you will know from your own experience that being in that state of creative flow is really physiologically healing. It's an amazing experience to get to regulate and be on the same page with another person being creative, sharing something personal in a way that's not too confronting, that can be paced by a therapist to be slowed down if it needs to be more contained, to give them a sense of agency and control. They get to choose materials, they get to experiment, explore, they can make mistakes, and they can teach you something or show you something and amaze you with what they can produce. There's no wrong outcome, and thankfully for teenagers, it's really fun. Wrong direction. It's probably good I'm skipping slides because I've got too much to say. So in my other world, as being originally an occupational therapist, I think when I first joined Milpera 20 years ago nearly, I was really trying to shed being an OT, didn't want to be a basket weaver anymore, not that I ever was, but I was really ready to put that aside and just really be an art therapist, be a psychotherapist. But I have come to really appreciate the OT lens, especially working with young people in this stage of their life. We really get to pay attention to first principles, do no harm, but do something. I would really encourage you in whatever capacity you come across young people of refugee background, be an effective tool for them. They are absolutely needing whatever small amount of change can happen from that interaction. We really like to see as OTs, people as a whole, they exist in a really complicated context. They come from these really complicated cultural and spiritual and political backgrounds. Their educational journey has often been absolutely fraught or non-existent. And we know that meaningful occupation is so important to anybody's life, wherever you're at along the lifespan. And for adolescents, some of those developmental tasks, which you've already heard about this evening by people more qualified than me, it's really about building identity. It's about starting to gain independence and be able to access the world. These are teenagers, so it's absolutely about the social aspect of their life and making those social connections. Ideally, you would hope in this age range, we're thinking about mastering executive functioning. That's a big task, but it is necessary for planning for your future self and for navigating how you're going to launch into the world. Oops, I did skip something I was going to say. Oops, we're really skipping it. Anyway, the thing that I was going to say then was, for you guys working with young people, think also not just about the developmental stage they're in right now, but think about what they might have missed. A lot of our young people might present to you like, oh, there's something going on. They don't really have the social skills I would expect. They don't really have, they're not a good student. They're not organized. They can't make a plan. They seem really, off. Think about what they have missed in their childhood, and often that actually comes down to the opportunity to play. For one thing, you would be amazed at the young people who walk into our offices at Milpera, strapping 16-year-old young men who are, amazing soccer players, and they come in and see all the sand tray toys and they're just absorbed, and they cannot, stop themselves from absolutely just engaging in play and being so drawn into telling a story, to shaping a context for you, to explaining something with less words than they might have needed otherwise, and actually helping them to move through some of the tasks and skills that those activities build is really important. But coming back to identity and that central task of adolescence, thinking about who they have been in the past, thinking about who they are right now in this time of potential chaos and great learning and great change, and then thinking about who they want to be as they move forward in the future. Art is really great for that, as well as movement and other creative activities, because you can really think about bridging those different parts of life. And if you do that physically or visually, it's actually a really powerful process. But if you can't access that kind of medium, then just actually sitting with young people and remembering, hearing about where they have come from, maybe the people who have been important along that journey, things that they need to spend time with to commemorate, and then things that they need to think about, how that experience served them, what they have taken from that, how they might want to embed that and integrate that into the person that they are now, what they might need to leave behind as well, how they have coped, how they have gotten here. It was mentioned by the panel this evening, thinking about the skills that helped them survive and get to this point. How have those things served them? Is that going to continue to serve them in the same way as they go forward? Or do they need to actually think about doing some things differently? Something else, another major skill of adolescence, and as we're working with them and building relationships, modeling trust, making mistakes and then repairing them is an absolutely vital skill in this work, and helping them to think about how that works relationally is really valuable. It's important to help them to explore what they're good at, what they enjoy, what brings some spark to their life. I'm not going to have time. I think I'm out of time. So I'm going to just skip forward. A few little things, just small tips for working cross-culturally. You can find out a lot of information about a person and their journey by knowing the visa number that they are on in this country and what that has meant about how they came to be here. Think about the country that they come from versus their ethnicity, what their original language is, all the other languages that they might have come across and have competency in as well. It is really worth knowing at least a little bit about the historical context of a country that a young person is coming from. It really makes a massive difference how many times a person has been displaced in their refugee journey and how that shows up for them as they settle. And of course, the impact of intergenerational trauma really can't be underestimated. it is so worth being curious and getting to know a young person's lived experience. What was it actually like where they came from? And you would be amazed if a young person knows the name of the camp that they lived in. Google it with them. Go on Google Images. Chances are you'll see the health clinic that they might have gone to. You might see the teacher that they once, sat with. You would be amazed at the images that you can find online and how empowering it is for a young person to share that with you and to be seen in that way. I'm just going to keep moving because I'm sure we have really talked about all of these things, I guess, except just to remind you that you are going to make cultural mistakes. You will say things and do things in a way that doesn't work, and you need to be really sensitive and observant to the reactions and the body language, and really read the room with young people. Be aware when you can feel, I've lost it here, we're not on the same page. And ask questions, ask them where you've got things wrong. Say sorry when you've got it wrong. Acknowledge what you don't know. They are the expert on their own experience. I guess, again, simple things. Be yourself, be authentic. Teenagers have a superpower. They can smell fake. They don't need you to be cool. You don't need to be anything other than you are, except invested in what you're doing with them. What you do needs to make sense to you. You need to have a sense of confidence in where you're going with it so that they can join you with that confidence. Use your own experience. You have all been teenagers. We've all been there. Of course, it will have been different for many of us compared to the young people that we're working with. But you can still relate. You are still, there on that human level. I am in the sweet spot of having teenagers myself, and I throw them under the bus all the time, talking about what they're doing, how that works, knowing some of the lingo. I don't 6-7 anybody, but you can actually get a lot of rapport and a lot of trust by showing that you actually know where someone is coming from. Be curious above all else, and be mindful of your own nervous system when you're with a young person. Young people, especially who've been through trauma, they don't just learn to regulate. They need to co-regulate before they regulate. And so being your own grounded system in the room is really important. You can always assume for this population that there is so much more going on than you know about. What is the presenting problem is the tip of the iceberg. You need to ask questions more broadly. You want to know about intergenerational trauma. You want to know their story, their grief, their loss, all those things. You also need to know, did they sleep last night? Have they had breakfast this morning? Do they have their friends? What's going on? Are they doing anything that's fun? How much are they on their phone? All of these things, have very real-time impacts on their well-being. Don't take things personally and be relentless. They will miss appointments. They will let you down, and that's okay, not their fault. You do not know all the things that they are trying to manage and juggle in their day, and being in the position, having that power to be able to offer again, to explain it again, to not take it personally that they didn't listen the first time or the third time or the fifth. They will get there eventually, but you also do really need to check for understanding along the way, because as Jacki said earlier, these young people are masters at appearing to know exactly what's going on, and they absolutely often don't. They really don't have the language of what we're talking about often. And be practical. Again, you want to be the best professional person you can be, get to the heart of what's going on, but you also need to realize they might be really stressed because they don't know how to get from your office to the next place they're going. So look it up on TransLink with them, do a journey planner. They might be really stressed because they can't see and they can't get their glasses because the optometrist texts the phone that's broken and no one's got a phone, and it's a drama. Call the optometrist, get the glasses posted to you, get them to them, do something practical. It will go so far towards building your relationship and building trust with this young person. It will take something off their plate for that day, and it really is actually a really important part of the work. You can be the best psychotherapist in the world, but if that kid is hungry and they're also really worried because they're a bit smelly that day because the washing machine's not working, then you're really not going to get that far with them. I think I'm sure. I'll stop there. I think you're going to get these slides, but I guess just the last questions. Sorry, I said I would stop. You might not have access to everything we have at Milpera. People often feel like, oh, but Milpera is easy for you, you've got this. Number one, those things were not handed out. Those things came from a lot of incredible leadership and a lot of incredible commitment. Buildings were donated by Jane and her family, who, you know, Jane started here in 2004, sorry. But so it doesn't just come easily, but it's so worth the investment of building your practice in a way that is engaging and welcoming, that can be a little bit more nuanced and culturally appropriate and sensitive. That means that you can advocate more, you know, more strongly for your young people, and to absolutely see them as these repositories of strength and potential, which they absolutely are. Yeah, I'll stop. Thank you.
Thank you, Bethany, for your great insights, and great to hear what HEAL's been doing and Milpera as well. And also your suggestions were fantastic. 6-7 is a good one as well. Before we move on to our final segment for tonight, I want to open questions to anyone in the audience for any of our speakers so far, and anyone joining online as well can put their questions through online, and then that can be answered as well. Does anyone have any questions? Yeah, we'll bring in the panel then. So I invite all of our guest speakers and also our panel members from earlier onto the stage. We have 2 questions. As they're slowly coming up now, does anyone have any questions in the audience? Or online? Is there any questions online? No? I think someone at the back has a question. Anna, is it? No? Oh, yes, we have a question at the back.
That's a very hard question. But for those who have worked with the Rwandan community in Brisbane or wherever in Australia, there is a lot of trauma, and there is a lot of stories that have never come forward. We have refugees who have never had a chance to go back since they left Rwanda in 1994. And some of their stories cannot be shared for a range of reasons. And those that will be able to open up either have gone through therapy or have seen their stories as part of that healing our social fabric. You will barely get a Rwandan person to open up, given that we still have a lot of, I guess, narratives that are repressed, and therefore in sharing your story, in sharing what had happened to you in, I'm looking at between 1990 to roughly 1999, that's when we saw young men and young women, young people taking up guns, either to be involved in the genocide itself or defend themselves. So the Rwandan case, it's quite unique in a sense that we still have so much narratives that have, I guess, so much narratives that are so sensitive in sharing them. It can open up a lot of difficulties for a lot of young men and women I see around. They tend to take a step back and withdraw from engaging with support services. My suggestion, if you were to engage with the Rwandan community, to be most, I guess, to sort of narrow down my sort of spin, is around getting to know the elders. We have people who are very respected, and they are either community elders or faith leaders, and faith being in a much more broader sort of scope. Getting to know them, they are more likely to get out more than any other person who may not be wanted, to be more specific. There's a lot of fear, a lot of paranoia, and a lot of that conflict that has not reached its final destination. And that is, yes, having have served the Rwandan community, I found myself incredibly difficult to get other stories, let alone a non-Rwandan person who either works for a government department or works for a mainstream service. We still have those very sadly difficulties and barriers that limit us and limit our members to come out for help.
Yeah, thank you, Emil. Another question.
That's such powerful feedback. Thank you. I think going into the detention centre environment, I was really aware of that. Prior to the program that I've been leading there, we had one GP who was doing 2 half days a week. He's a phenomenal GP, but it's not possible to serve the healthcare for 300 young people in that context. And so when we put together the case around that, it was essential that we had nurse navigators and we had a multidisciplinary team. Not just because of the amazing expertise that comes with having experienced nursing staff and speech and language therapists and OTs, but it also means that we provide care and advanced First Nations health workers. It means we can provide care in teams. And that really came home for me today when I was catching up with a young person down in the sections in the detention centre, which is where I do most of my work. And this young person had been with one of our nurse navigators, and that nurse navigator went on to a different role. And we know that this happens, that the healthcare system has this, I guess, someone blows the whistle and everyone changes places. But we had already done a warm handover as part of our team and kept that as close as we could. And that was not only about the relationship that one individual nurse had with the young person, but managing that warm handover over time. 1. 2, it was also set up in our way of working that we had our multidisciplinary team meeting in the background. So for that young person or any of our young people, they can tell their story to any one of us the once, and we have that professional responsibility to share it with each other and to do that warm handover at a time that works. And my hope is that that's the success of the program, is that we're able to keep working with young people even when we have, it's a sustainable program when you can change who is in the team, but the team functions in such an effective way. But I absolutely agree that, repeated systemic abandonment exacerbates attachment trauma.
What are your thoughts as a whole panel? Open to everyone on the panel. What are your thoughts?
I don't think I'm necessarily the person to answer this, except to say in our experience at Milpera, we do come across some of the stories that would end up in your area, unfortunately, particularly around marriage and relationships. It's incredibly sensitive. It's incredibly challenging to talk with families about and to manage expectations around, to be able to prioritise safety and to really put the needs of a young person first while they are existing in a really complex space of acculturation. It's also, I guess, without trying to go off topic, but just thinking about adolescents acculturate at a very different rate to their families and to their parents, and so the expectations of a young person compared to the expectations of their parents around some of those decisions around work, around relationships, can be really wildly different. It's not a space that I feel like I have answers around, except that I can say that any population that you're working with that has all of these layers of complexity and vulnerability is definitely going to come, be more visible in those sort of spaces. I think that young people in those situations, they require absolutely relentless advocacy, and I think that being people to have a voice for them when we do have a lot more power than them is absolutely essential. Over the years, it's not something that happens all the time, but over the years we've definitely made a lot of reports about young people in vulnerable situations like that. It can be frustrating because you don't always know where it lands and you don't always see an outcome. But I think being prepared to always, if you have the instinct, if you have the concern, if you hear things happening in the community, is, speaking up is absolutely essential.
Thank you so much for your question. I was a bit shocked because I was like, whoa, this is not a question I was expecting. And thank you to everyone who's already asked questions in the audience. For me, your question was very intriguing because the first thing that came to mind was about, I think back to my own experiences and the people that I've known in the community who've been through some very, very difficult things, especially through their settlement journeys. And I'm a believer that settlement journeys never really end. They just continue to progress in different phases. And I think education is key. Sometimes these families, mums and dads, people that we know from who come from very, very traumatic backgrounds, don't know that what they're doing is actually wrong. I can speak to this from a DV perspective, having done a lot of work in that space in the community with my own story, but advocating for it. Education is key. Sometimes our loved ones don't mean to do the things that they do. It's just when they first arrive, it's like health check. Okay, you've got your visa. Are you legally allowed to enter the country? And then, okay, let's get you to a hotel. And I'm referring to the very, very first couple of days when families arrive to Australia. And I think that getting that education as soon as possible, and that will look very, very different for different service providers, families, and how you approach it. It is ultimately case by case at the end of the day, and trying to adapt to families, young people's needs when they first arrive to Australia. But I'm a big believer that educating is really, really important the moment that they arrive, because what they might end up doing can sometimes cost them in the long run. And some of them, like I said, they don't mean to do what they do. So, that's the only point that I would add to that conversation.
Beautifully said, Huda. I think that point about the settlement journey never finished. My grandfather said something similar. I think both to your question and to the first question, as a clinician, we have a responsibility to acknowledge that no human should experience that, and that is part of you, but not all of you. I would say that the times that I've had the opportunity to provide healthcare for young people in that kind of situation where I suspect that there is a degree of sexual exploitation or other exploitation has actually been around providing what I think of as standard care, but really that heads assessment, and starting the conversation around either sex or substances. And working in a substance use context, often a young person will come in and ask questions and seek help. And the context of their substance use allows me to understand the many layers of what's happening beyond all of that. I made a comment in my talk about Australia being bathed in alcohol culture, but we also know that for particular substances, there is a whole range of culture that's associated with that. And I'm thinking here about amyl nitrate or methamphetamine, substances that are wrapped up in particular cultures. And so when a young person shares things that are not, I guess the other piece around that is thinking about developmentally appropriate substance use, by which I mean a 14-year-old is more likely to use inhalants and cannabis, and a 25-year-old is more likely to use alcohol and cocaine. And in the middle, it just depends on what else is happening for them. So when we get a sense of things that are not developmentally appropriate, particularly around substances, but also around sex, then they can be those flags. And around sex, being specific around, so the risk questions that I will ask if a young person's ready to engage around that include group sex and sex whilst intoxicated, and then asking around the substances. And often those can be the small things that just allow the start of that conversation to happen in the clinical context. And when a young person, particularly a young person over the age of 17, shares that kind of information, then what would they like us to do with it? And then having some ideas or some options, 2 or 3 options about what a young person might want to do. But it all starts in those very brief nuggets of a conversation, like where are you up to with sex? Do you have crushes on males, females, both, not sure, neither? And just progressing the conversation. It's a really tricky area of care, and I think acknowledging that young people's first disclosure of these kind of situations can happen, on any random Wednesday in a 2 o'clock appointment is something to be well prepared for.
Thank you, and thank you for your questions. I'll just ask if there's any questions online as well that we've received. No? Would anyone else like to ask any questions? Okay, I might then. I have a question for the panel, and it kind of is reflecting on everything we spoke about today. So I'm curious to hear if you have anything to share or anything new in particular. My question is, if you can name kind of one thing you feel works really well when you're working with adolescents from a refugee background. So open to all, but anyone in particular that's working directly with adolescents, I'd love to hear from you.
I think just acknowledging shared humanity. You know, like everyone's got their professional roles and their personal backgrounds and their individual stories, but in that moment we're here as humans providing care for another human. And I think whatever it is that you need to think or feel or to consider to be in that space, then that's what allows us to work most effectively.
I think simplifying explanations right down to first principles. I think one of the best examples of that given tonight was about the swimming pool. Like I find that when I'm discussing a health topic, I use lots of pictures. I Google images all the time, a lot of explanation about how things work, because that health literacy that most white Australians have grown up with often just isn't there. So yeah, really taking things back to very, very first principles. Otherwise we miss an important part of communication, and you know, the important messages are lost because the basic information isn't there.
You go, and then I'll...
Two things which comes to mind. One is the idea of empathy and humility. That if you practice that, you do not just provide the care, but you restore hope and dignity. And for a lot of young people, they've never been grounded that they are safe, they are seen, and are being heard. So part of your role is to provide the care and restoring that dignity, hope, and a sense of belonging. The other final thought is around trust and allowing that time where there's a room for flexibility, utilize that in a way that will build trust and relationships. From a community perspective, we share news, we tell. If I have presented myself at your local practice and I received a particular care, that experience will be shared around. And you wouldn't want to be known as that person that, you know, is known in community that, you know, if you show up, if you they will just hear you and tick the boxes and move on. So what you do as practitioners, we talk about experiences in your clinics and in your practices. People will come up and in Logan, to be more specific, and certain places in the in Ipswich, people will identify that if you go to this practice, that person will not just look after you, but they'll care and take that extra mile. So we talk and we share the good news, and we also share those experiences that haven't been really positive. And trust, time, and consistency will usually alleviate some of the challenges that may remove community from engaging and connecting.
I just want to say, young people love it when you're pleased to see them. So even when you're tired, or they've been an hour late for an appointment, or whatever it is, just, you know, bring some energy to the space. Yeah.
as like a perspective from a young person and just positive things I've experienced with medical professionals or just any profession really is just branching off what Emil said, just creating a true like safe space with the young person and truly listening to what we want to say and truly understanding where we're coming from. It really comes a long way.
Definitely. I would say the little things really count. Whether it's, for example, the interpreter asking whether you would prefer male or female, would you prefer it in person or over the phone? Simple things like that can make the biggest difference. And it's that attention and care that really does come through that we do see. So that always makes the biggest difference. And also for young people particularly, really make space for our contradictions. And I'm butchering the saying, but there's the truth, but there's multiple versions of the truth. Sometimes these young people are going through very complex, confusing, and very contradictory things that they may share. Make space for that, not to question that, but to really let it sit for what it is, and that can make us feel very seen. So
thank you to our panelists, and for everyone's questions as well. That concludes our section, so if you'd like to take a seat. Thank you everyone for joining tonight. Had so much rich discussions, and I've taken away a lot of new information as well, and I hope you have too, and everyone who's joined online. This concludes our program for this evening. I have behind me a QR code with an evaluation. If everyone can scan and give any feedback, that would be really great. Also want to talk about the resources available. So when you were entering, there were so many resources laid out on the table. Feel free to take some of that. There's also more available on the Refugee Health Network website. There's also a beautiful book, Tariku, which you can take a copy of. It's a beautiful storybook. And there's also a QR that I see some at the back actually. There we go. There's a beautiful book we have here, a children's novel, which you can take one. And there's also a QR code for any donations if you'd like to make a donation for the reprinting of the book as well. But thank you everyone. Thank you to our guest speakers. Thank you to Mahadeo Refugee and Multicultural Health Service, the Refugee Health Network for organizing this event. And thank you again to Brisbane South and Brisbane North PHN for supporting and organizing this event as well. I think everyone's quiet because they're doing the evaluation. But once you've completed the evaluation, feel free to take the resources. Do some networking, that's right. Yes, and if anyone hasn't finished their food as well, you can eat that.